Good morning, ladies and gentlemen. I'd like to say thanks to the organizing team for giving us this opportunity to present this work on the efficacy of second-line Dolutegravir-based ART, comparing it with boosted protease inhibitors in children and adolescents living with HIV at 96 and 144 weeks. And this is from a pooled analysis of ODYSSEY and CHAPTERS 4 trials, and I am honored to present on behalf of this entire team. So in terms of the background, we are very glad that Dolutegravir-based ART has been rolled out initially to the adults, but now to the children. And we have seen some data that ODYSSEY and CHAPTERS 4 trials individually showed that Dolutegravir-based ART was superior compared to the boosted protease inhibitors at 96 weeks, but also sustained at 144 weeks in children starting second line. So this pooled analysis was actually done to get more precise treatment effects. So looking at the two trials, first the ODYSSEY trial enrolled children who are on first line and second line. So here we are focusing on the children that were in the ODYSSEY B trial, in the ODYSSEY B arm. Who are starting second-line ART and were randomized to either Dolutegravir-based ART or the standard of care, which was majorly lopinavir-ritonavir or atazanavir-ritonavir. A small number of children were on darunavir. So for the CHAPTERS 4 trial, this was a trial of children that were starting second-line ART, and it was a factorial design. So the initial randomization of first step was a randomization to Dolutegravir or the PIs, which were lopinavir-ritonavir or atazanavir-ritonavir or darunavir-ritonavir. And then the second step was a randomization to the backbone, so either ABC3TC or AZT3TC or FTC-TAF. And for this analysis, we did not include children that were actually randomized to darunavir-ritonavir because there were very small numbers of children in the ODYSSEY trial. So the aim of this analysis was to estimate the longer-term efficacy of a DTG-based ART, comparing it to the boosted PIs, a second-line ART in children and adolescents living with HIV, using data from the ODYSSEY and CHAPTERS 4 trials, and to compare DTG efficacy to particularly two boosted PIs, that is atazanavir-ritonavir and lopinavir-ritonavir, by intention to treat analysis at 96 weeks. So for the methods, we actually included children definitely from the ODYSSEY and CHAPTERS 4 trials who initiated second-line ART, were randomized to either Dolutegravir-based ART or atazanavir-ritonavir or lopinavir-ritonavir, and were weighing 14 kilograms and above. So our primary outcome, similar to the CHAPTERS 4 trial outcome, was a proportion of children that were alive with a viral load of less than 400 copies per ml at 96 weeks and 144 weeks. But we also did a secondary analysis using a cutoff of less than 60 copies, as well as less than 1,000 copies. So for the analysis, we estimated the difference in proportions using an intention to treat analysis between the group that were on DTG compared to the group that were on the boosted PIs at 96 weeks and 144 weeks. We also went ahead to look at, to estimate the difference in the unrandomized treatment effect for the children that were on DTG compared to those on boosted PIs. And you'll see that this was basically to adjust for the switch from boosted PIs to DTG, especially for those in CHAPTERS 4. And then we also did an exploratory analysis comparing efficacy of DTG with the two PIs. So that is DTG versus atazanavir-ritonavir, and then a DTG versus lopinavir-ritonavir. So the baseline characteristics for this group of children, we'll see that 2/3 of where is the pointer? Do we have a pointer? No. Okay, all right. So two-thirds were from the CHAPAS 4 trial, highlighted in red, and really the biggest proportion were from Africa. There you go. And the groups were comparable, really. So looking at the efficacy of DTG compared to the boosted PIs at 96 weeks, for the intention treated analysis, should be on your left. Up here, using the cutoff of less than 400 copies per mil, we see that 8% more children in the DTG group were able to achieve viral suppression, less than 400 copies per mil, with the 90% having suppressed in the DTG arm compared to 83% in the boosted PI group. And for the individual trials in ODYSSEY, the difference was 5% and 10% for CHAPAS 4. Yeah. But we'll see that on your far left, yes, the benefit is consistent when you use a cutoff of less than 60, as well as a cutoff of less than 1,000 copies. So looking at efficacy of DTG compared to the boosted PIs at 144 weeks in the intention to treat analysis, again on your left, looking at the combined analysis at the top, with a cutoff of less than 400 copies per mil, we see that 5% more children in the DTG were able to suppress compared to those on boosted PIs. So we had 86% children suppressed on DTG compared to 81% of children in the boosted PIs. And this benefit is evident even when you have a cutoff of less than 60 copies or less than 1,000 copies. But you will see that at week 144, across the different cutoffs, the viral suppression is lower compared to the suppression at 96 weeks. So we actually took some time and looked at the ART switches before week 144. And we saw that in both trials, there were very few switches in the Dolutegravir arm. In the ODYSSEY trial, there were very few switches from the boosted PIs to DTG. However, looking at the graph on your left, before week 144, there were 32 children that switched from boosted PIs to DTG-based ART in the CHAPAS 4 trial, okay? And this was majorly due to changes in the treatment guidelines or for simplification. So this definitely contributed to the efficacy of DTG in the intention to treat analysis at 144 weeks. So what we did is we did an unrandomized analysis, which may be similar to maybe per protocol analysis, and we adjusted for the switch from boosted PIs to DTG in CHAPAS 4 trial. So the plot on your left is what we have already seen at 144 weeks using the intention to treat analysis with a 5% benefit for DTG in the combined analysis. But in the unrandomized treatment on your right, you will see that the difference increases to 7%, having adjusted for the switches from boosted PIs to DTG in the CHAPAS 4 trial. And looking at CHAPAS 4 trial alone, again, this was at 144 weeks with the intention to treat, but on randomized treatment, the effect actually increases to 10%, showing that the switch or the change in guidelines also contributed to this difference. So we also went ahead to look at the efficacy of DTG compared to the two boosted protease inhibitors. So that is atazanavir, ritonavir, and lopinavir, ritonavir. So the first row is what we have already seen, okay, with 8% benefit for those on DTG compared to the two PIs in combination. And we'll see that for the next two rows, dolutegravir-based ART is superior to atazanavir as well as to lopinavir. But looking at lopinavir compared to atazanavir, ritonavir, there is a difference, but it is not significant. So in conclusion, virologic suppression is superior on dolutegravir-based ART as second-line ART compared to the boosted protease inhibitors at 96 weeks and in the longer term at 144 weeks. And these results are similar even when even after adjusting for the switches due to changes in treatment guidelines in the CHAPTERS 4 trial. DTG was also similarly superior to atazanavir or lopinavir ritonavir at 96 weeks, but we've seen already the similar results in CHAPTERS 4 trial. So this pooled analysis provides stronger evidence supporting the recommendation of dolutegravir-based ART for second-line treatment in children and adolescents living with HIV, and would like to acknowledge this huge team of contributors, the participants, the funders, and the sponsors. Thank you very much.